liver to pancreas. We know that two important organs in GI which are affected by alcohol is liver and pancreas. And the pancreatic problems can be very serious also, very complex also, and they need to be dealt by specialists. So, but even for the specialists, the uh, dealing of pancreatitis can be a problem and challenging. And this is a very wide topic. The problems can be so many. We cannot cover in short span of time. I would like to cover some of them important issues in this talk. Coming first to why do some of the patients who are consuming heavy alcohol, only a few percentage develops alcoholic liver disease. This is a problem question asked by many of the patients, and definitely we don't have a good answer to this problem, as the reasons for this problem is there is difficulty in accurate determination of alcohol intake. It has been seen that people who are consuming large amount of alcohol, 80 to 100 grams of alcohol, at least for 8 to 10 years or 12 years, they can be only ascribed that this is due to alcohol intake. Secondly, the type of pattern of alcohol intake matters, that different alcohol beverages which are taken, they also matter. And lastly, as Dr. Setu Baba has mentioned, when we don't have any answer, we blame it to genetics. Genetically, it has been seen that there are certain genes which are responsible, have been shown to be defective in patients who develop chronic this alcoholic pancreatitis. That is mainly CFTR dysfunction, which is mainly because this is a main bicarbonate regulator gene, which is disturbed by patients who are consuming large amount of alcohol, whereas the other genes which are linked to pancreatitis like PRSS1, SPINK1, CPA, they don't affect the people who are consuming alcohol. As mentioned in the previous talks, that alcohol is metabolized by two pathways, oxidative and non-oxidative pathways. How alcohol leads to pancreatic injury, it has been seen that the oxidative pathways leads to production of acetaldehyde and reactive oxygen species, which has a destabilizing effect on zymogen granules and lysosomes, leading to pancreatic injury. Secondly, the non-oxidative pathways leads to fatty acid ethyl ester production, which also destabilizes lysosome in the acidoid cell, leading to intracellular activations of enzyme auto digestion of gland. So this happens in few people. Not everybody is going to get pancreatitis. And recently, as mentioned by in first talk, that alcohol leads to bacterial endotoxemia, and there is increased LPS secretion and leads to progression of alcoholic pancreatitis. So this is the main genetics has been shown to be involved in patients who develop alcoholic pancreatitis. Alcoholic pancreatitis patient can develop in three forms. One is a acute pancreatitis, as they can present as mild, moderately severe, or severe pancreatitis. The second group of people, they come with chronic pancreatitis with recurrent attacks of pain. And thirdly, they come with chronic pancreatitis with some endocrinal or exocrine insufficiency. Although there is no hard and fast separation, we can have a good amount of overlap between these different groups. Coming first to the management of acute pancreatitis, there are certain issues. Although some of these patients who are having moderately severe pancreatitis, they are managed in high dependence unit or ICUs, where we need to take care of their IV fluids, analgesia, antibiotics, nutritional, and how far to investigate these patients, leading to routine or CT scan examination. A word about IV fluids. The choice of IV fluids, there was controversy in the past, but now we know that ringer lactate is the preferred IV fluid used in patients with acute pancreatitis. Why it is so? It has got an anti-inflammatory effect on pancreas. Secondly, the cyst persistence was seen to be lowered in patients who were given ringer lactate as compared to normal saline. The patient had lower mortality when RL was infused in these patients. The second is how what is the amount to be given to the patient? The, there are studies in the form of, they say that we give a bolus of 20 ml per kg per hour in first 4 hours versus 10 ml per kg per hour in first 4 hours. To begin with, there was studies were favoring higher dose, but now they favor that the patient tend to get more complication when this amount is given as compared to 10 ml per kg per hour. Whereas the next is how much fluid should be given later on. The 3 ml per kg per hour rapid infusion versus non-rapid infusion, there are also studies, and it has been seen that the rapid fluid transfusion and hemo concentration, these both are significant and independent risk factor for persistence of organ failure and mortality. Now, the consensus is non-rapid infusion may be better in patients who are admitted in ICU. The second important issue remains the analgesia, because acute pancreatitis is a very painful condition, and we have two groups of drugs, NSAIDs or opiates. The adverse effects and the benefits we need to weigh. NSAIDs, they have a problem of renal failure and GI bleed, whereas opiates, they have a problem of ileus, respiratory depression, and sphincter of Oddi dysfunction. It has been seen, we have trials in which compared tramadol with diclofenac, they were found to be equally effective. Recently, we have a lot of data on pentazocine, which is a kappa opiate agonist, is better than diclofenac and analgesia in acute pancreatitis. Although it has been seen that pentazocine also increases intraductal pressure in the pancreas, as well as it increases the pressure on sphincter of Oddi, but overall the pancreatitis outcome was not worse than as compared to placebo when pentazocine was given as an analgesic. So this is a very good drug which can be used in patients with acute pancreatitis in ICU. Coming next to antibiotics, which is a very important issue because it is very daring to treat a patient of severe acute pancreatitis without antibiotics, especially in private practice. Although the meta-analysis says, we have meta-analysis of different trials which says that there is no need of giving prophylactic antibiotics, and in fact it has shown there is a problem with use of prophylactic antibiotics. These people, they had more resistant infections who were given prophylactic antibiotics, gram positive infections, as well as more fungal infection. But in spite of reading so much of literature, it is invariably, when the patient is admitted in ICU, we try to give some sort of coverage to the antibiotics. Definitely, there are certain indications in which antibiotics should be given to the patient whenever we see that there is signs of sepsis in the patient. There is proven extrapancreatic infection, which can be in the form of respiratory infections or UTI or any other site for infection. Antibiotics should be given to the patient. And lastly, the aspirate from the necrosis or collection, which is found to be positive for infection, the antibiotics are going to be of use. Which another indication is a cholangitis, not so important in case of alcoholic pancreatitis, but definitely in patients with gallstone-induced pancreatitis, cholangitis remains an important indication for starting antibiotics. Next question is, what is the antibiotic drug of choice? The best, obviously, the drug which has got best penetration in the pancreatic tissue, that is carbapenems, fluoroquinolone, and metronidazole. These are the three group of drugs which are found to be good in patients with pancreatitis with pancreatic necrosis. Lastly, coming to the nutrition part, which is very important in patients who are admitted in ICUs, it has been seen by different meta-analysis that enteral feeding is found to be better than parenteral feeding. This is very important because to initially enteral feeding may not be possible because of persistent pain, vomiting, nausea, or ileus. But as soon as the patient becomes, as soon as the patient can take orally, the enteral feeding should be started. There are meta-analysis comparing enteral feeding with total parenteral nutrition, and it was seen that definitely the mortality, the infection rate, and the outcome was better in patients who were started on enteral feeding. The second is tube feeding in the patients who are intolerant to oral feed. But what should be the route? Nasogastric or nasojejunal? The issue was studied in different trials, and it was seen that nasogastric was found to be as good as nasojejunal. As these were compared as far as the mortality is concerned, as far as the infection is concerned, or tracheal aspiration is concerned. Tube feeding is uh, in both the ways are equal. Where to put a nasogastric tube is much easier than nasojejunal tube in patient who is having severe acute pancreatitis and having ileus or other problems. The goal of feeding is to give adequate nutrition, 25 to 30 kilocalorie per kg, and protein intake should be at least 1 to 2 gram per kg body weight. Next comes the pain management in patients. The second type of patients who present to us as chronic pancreatitis, chronic pancreatitis with recurrent pain abdomen and with endocrinal, with or without endocrinal or exocrinal insufficiency. Pain management in chronic pancreatitis should follow WHO pain relief ladder pattern. Mild pain can be treated with non-opioid analgesics, and if not responding, adjunct therapy can be given. Mild to moderate pain, we can add weak opioids along with adjunct therapy. If still not responding, strong analgesics can be given. And ultimately, if the patient is not responding, some sort of endotherapy or intervention in the form of nerve block that can be given, because we know that the pathogenesis of chronic pancreatitis pain is multifactorial. We have ductal hypertension, we have neuropathic pain component, we have inflammatory pain. So all these can be taken care of. Ultimately, we need some sort of analgesia for these patients. The second important drug which has been studied in patients with recurrent pain abdomen in chronic pancreatitis is antioxidant. The studies are there. We have trials in alcoholic patients. Manchester trial is there, which showed that these patients did not respond to antioxidant therapy, but uh, important trial from All India Institute showed that the methionine containing antioxidant combination with organic selenium, beta carotene, vitamin C, and vitamin E was found to be very effective in patients. Although the trial was in non-alcoholic group, younger patient, and they were not opioid dependent. So it was found to be very effective. But if, as we don't have much to offer, we can try these combination in alcoholic patients also. Adjunct medicines, these are very, very important. Patients who are not responding to normal analgesics can be given adjunct medication in the form of tricyclic antidepressants, as the pathogenesis in chronic pancreatitis pain is one of the mechanism is neuropathic pain, neuronal plasticity, which has been documented to be a cause for chronic pancreatitis pain. The gabapentin, pregabalin, selective SSRI alone or in combination with opioids can be used. And it has been seen that pregabalin binds to alpha 2 delta subunits of voltage dependent calcium channel blocker. Thereby, the release of excitatory neurotransmitters are reduced and the pain improves in these patients. As I have already mentioned, the patients, second group can come with, third group can come with patients who can come with only exocrinal or endocrinal insufficiency. I will be covering exocrinal insufficiency because these enzyme therapy, which is used for exocrinal insufficiency, has been also tried in patients who to prevent pain also in chronic pancreatitis. The mainstay of treatment in exocrinal pancreatic insufficiency is pancreatic enzyme replacement therapy or PART, and this is combined with lifestyle modification. For pain, we need non-enteric coated formulation, and for malabsorption, we use enteric coated formulation. The agents used for PART are extracted basically from the porcine pancreas, and PERT dosing is adjusted. A few words about PERT. It remains the mainstay of therapy in exocrine pancreatic insufficiency, along with vitamins, lifestyle modification, and for pain, we are using non-enteric coated preparation. The starting dose of PERT is 50,000 units of lipase with meals and 25,000 units of lipase with snacks. The pancreatic enzyme should be spread over throughout the meal. The capsule cannot be swallowed, and it should be, if person cannot swallow the capsule, that can be opened and placed in an acidic medium or in a juice, and patient should take it with cool water to prevent oral ulceration. There is no maximum dose of PERT in adults. Almost 1 lakh units of lipase with meal has been tried in patients. It should not exceed this. We have the important point in these patients is that the dietary fat restriction is normally given to the patients of chronic pancreatitis, which should not be given as patient if the substrate is not there and we are giving PERT. This is not going to help the patients. A very high fiber diet should be avoided. Addition of a PPI can be used if PERT is not effective, and if one PERT preparation is not active, we can add another. We can try another preparation. The adverse effects are there: fibrosing colopathy. Theoretically, because this is porcine in origin, we have theoretical risk of viral transmission, abdominal pain, diarrhea, and some. It should be used with caution in patients with gout or renal impairment. But other emerging alternatives are bovine preparation, fungal diastasis, human lipases are also coming up. A word about pancreatogenic or diabetes or type 3 diabetes. Type 3C diabetes, the prevalence is around 15 to 20% in all Southeast Asian population. The major criteria, because this is basically pancreatic diabetes, these patients must have a presence of exocrinal insufficiency. So the monoclonal fecal elastase should be done, or some sort of direct pancreatic function test should be done. Pathologically, pancreatic imaging should be done to prove it as chronic pancreatitis, and they should have absence of diabetes mellitus 1 associated autoimmune markers. Although this is a domain of endocrinologists, but we must know some of the things. These minor criteria are absent pancreatic polypeptide secretion, impaired incretin secretion, no excessive insulin resistance, HUMA-IR, impaired beta cell function, HUMA-B or C-peptide or glucose ratio, low serum level of lipid-soluble vitamin, especially A, D, E, or K. The treatment of these patients is metformin is a very good drug because this can help in patients who have HbA1c less than 8, that means early stages of even type C diabetes respond to this. Sulfonylurea should be avoided. We don't have much data of glycides in patients with pancreatogenic diabetes. Ultimately, insulin remains the treatment of choice. A word about total pancreatectomy with autologous islet cell transplantation. This is a new thing coming up, not easily available in India, but this can be tried in patients. We don't have anything else in which this is a basically complex procedure in which removal of whole of pancreas is done with duodenum, leading to lifelong pancreatic exocrinal and endocrinal insufficiency. The treatment of exocrinal insufficiency can be taken care by supplementation of PERT, and the control of surgery-induced diabetes requires insulin. The technical aspect is total, I will just show diagrammatically. What is done, pancreas which is removed, this is taken to the lab, and from that it is auto-digested and the islet cells are removed. A preparation of islet cell is made and it is infused inside the portal vein directly. And the engraftment of these islet cells remains in the liver. So liver acts as a pancreas, sort of, and this can take care of pancreatogenic diabetes. So this is all about. Thank you.